Chest Association organized a webinar on NTB, role of private practitioners. Every year, Tuberculosis Day is observed with particular theme. In 2021, the theme is The Clock is Ticking. According to WHO, it emphasizes that world is running out of time to act on the commitments made by the global leaders to end tuberculosis. This is especially critical in the context of the COVID-19 pandemic that has put NTB progress at risk. So with this, I welcome and invite Dr. Archana Kothari, a dynamic president of Indian Medical Association Nagpur, for her introductory speech. Over to you, Archana.
Thank you, Sushma. Thank you for the kind words. Uh, First of all, I would like to thank Indian Vidarbha Chest Society for getting associated with this very important topic on uh, tuberculosis. We all know that we want to end tuberculosis, and I just called Madam, and she said yes, we will do it. And I'm very much thankful to you, Madam, for all this kind gesture. On behalf of Nagpur IMA, I would like to welcome all the speakers, chairpersons, and also the attendees who are attending this webinar. You all know that this program is to raise public awareness about the devastating health, social, and economic consequences of tuberculosis. Uh, we all know that tuberculosis is one of the deadliest infectious disease, and almost 4,000 people are losing life in a single day. And we all know that it is totally curable and it is preventable. But there are some things that we practitioners have to follow. That is what we have to do, that Dr. Aniruddha Kadu will tell in his speech in National Tuberculosis Eradication Program. Then we know the basic things that we have to do before diagnosing tuberculosis. But the interpretation of the test, that Dr. Sumit Chaudhary will be guiding us on that, on the interpretation of the tests. And the most important part, drugs, we all know what are to be used, how to be used, but judicial use of uh, drugs in tuberculosis is very important. And we have to revise our knowledge we should revise our knowledge every day. And for that, writing the prescription in case of a tuberculosis patient is very important. And as a general practitioner, as a basically, other than physician, we all are general practitioners only. As a gynecologist also, I consider myself as a general practitioner for tuberculosis. So I should also know what we have to write, how we have to write, how judiciously the drug should be used, and that will be covered by the dynamic speaker, Dr. Gyan Shankar Mishra. So I welcome you all to this very important webinar on tuberculosis. Uh, Thank you, Sushma. You can conduct the proceeding further.
Yes, Archana. Now I would like to invite Dr. Radha Munje. She is my friend also. She is professor and head of the Department of Respiratory Medicine at Indira Gandhi Government Medical College, Nagpur. She is a member of Governing Council ICS, and she is recipient of SN Tripathi Oration in NatCon 2015. She was organizing chairperson of NatCon 2015, and now she is a president of Vidarbha Chest Association. She has published various papers in national and international journal. She is a chairperson of Ethic Committee of GMC Nagpur as well as National Institute of Miners Health. She is a member of NTF, STF, STN, RNTCP, and I would like to congratulate her because she received Best Professional Award from Professional Body by CTD on the World Tuberculosis Day, March 2021 at New Delhi, at the hands of Health Minister Shri Harshavardhan. So congratulations, madam. And now I invite her for introductory speech.
Thank you, Sushma, and thank you, Archana, and her whole team of IMA. It's good to see all TB workers on a platform with a common intent of increasing the awareness. Let me add just a few lines before we go on ahead with the scientific program. The government of India, along with our own Prime Minister Modi ji, has declared to end TB by 2025 in India, 5 years ahead of the global goal of end TB. This could have been very easily possible, not if the COVID would not have struck all over the world as well as in India, and whatever we had achieved in last 8 years have been minimized very considerably in last 1 year of COVID pandemic, because the whole workforce of TB, including the diagnostic modalities, had been transferred for COVID work, which was the need of the hour. But what we have learned in this COVID pandemic is that nothing is impossible. So, if there is an administrative commitment, the funds will flow, the people's will come, they will work, and anything and everything that you want to achieve can be done. So that is why we have to now move back towards the National TB Elimination Program. RNTCP has been renamed this. And we have to understand that each one of you, as Archana said that she believes she is a general practitioner, we believe all of us are basic medical graduates, and hence diagnosis of tuberculosis and its treatment should be a very, very easy aspect and should be followed as per protocol or guidelines given in the NTEK. And there are various stakeholders. It's not only like people who are in medical colleges, or TB is not a question of only public health program. It's about the private practitioners, it's about the NGOs, it is even about the people who have been cured of TB, because they are working as ambassadors for this program. And nothing can be emphasized which is as big as Mr. Amitabh Bachchan, who always comes forward for the TB campaign and brings about awareness. So people have to shed inhibitions and come out in the open. And that is why in almost all of the TB meetings and programs, we invite the patient's representative to come forth with experiences. Apart from that, the government of India has launched workplace policy or regarding TB, so that any patient who is suffering from TB will not face stigma at workplace. Plus, he will get some consideration so that he can take his medicines, tolerate his drugs if he has some adverse reactions, and does not miss on daily wages and continues to work at his workplace. And many multinational companies and I should say national multinational companies have come forward and pledged on World TB Day to have a work environment which is TB friendly for the patient. So it suffices to say that it is everybody's responsibility to see that we end the dream of ending TB by 2025. It is not a very big task. Very small things which we can do would contribute in a very, very major way. And how we are going to move ahead would be aptly told by Dr. Kadu Sumer and Dr. Gyan Shankar Mishra. And all the best, and thank you IMA for giving this wonderful opportunity to Vidarbha Chest Association to join with you and go ahead with this World TB Day CME. Thank you.
Thank you, Dr. Radhamunji ma'am. Now, I would like to welcome Dr. Rajesh Balla sir. He is a chairperson for this CME. I would like to introduce him first. He has done MBBS and MD from the Government Medical College, Nagpur. He was founder secretary of Vidarbha Chest Association in the year 12 and 13. He was president of Indian Medical Association Nagpur branch in 2008 and 9. He is a life member of Academy of Medical Sciences. He was president of Association of Medical Faculties. Currently, he is working as a private practitioner, as consulting chest physician, and he is doing this since 1989 till date. He is a tuberculosis and chest specialist at CDRC Sadar from 1990 to date. Uh, he has worked as a consultant tuberculosis specialist in the healthcare division, and he was lecturer in the tuberculosis and chest TB department in the year 1998 at Government Medical College, Nagpur. So I welcome you, sir. And now I hand over the mic to for the further proceeding.
Thank you. Can you hear me?
Yes, sir.
Okay, I believe the first lecture is by Dr. Aniruddha Kadu.
Yes, sir.
So Aniruddha Kadu will be speaking on National Tuberculosis Eradication Program. I'll just give a short brief. In 1961, the NTI Bangalore was formed, and then the first National Tuberculosis Program was uh, formed, and that was from 1961. Gradually, as the newer drugs were introduced, as new diagnostic modalities came in, as the epidemiological situation changed, as our goals changed, the program has undergone certain changes. It became RNTCP, and right now we have the ambitious program of eradication of tuberculosis till 2025. Dr. Aniruddha Kadu will tell us about this program. Dr. Kadu is currently is working with WHO as a medical consultant for National Tuberculosis Elimination Program since the last 7 years, and he's been posted in Nagpur. Before this, he was working as a WHO specialist in the government in Bihar from 2014 to 2017, and there he did a huge work for in devising innovative strategies for TB elimination, like piloting ICT-based 99 dots technology UATBC, for engaging private sector, which is what we are worried about now, intensified case finding in high-risk group for reaching the unreached, and upscaling the newer diagnostic techniques. And then he came to Nagpur as a WHO specialist to the government of Maharashtra. He has done his MD in community medicine from SRTR Government Medical College, Ambezogai. And let's hear him what he has to say about this National TB Eradication Program. Dr. Kadu, please.
Thank you, sir. Thank you all. Thank you, organizers, for inviting me for this talk. So, and thank you, Ballar sir, for giving us such a nice introduction. So, how much time do I have? So accordingly, I'll modify my presentation.
I believe 20 minutes.
Okay. So are my slides visible, sir?
Yes, they are visible.
Okay. So I just want to clarify first that it's a National Tuberculosis Elimination Program. Previously, we used to call it as RNTCP, Revised National Tuberculosis Control Program, but now it is a elimination program. And definition of elimination for tuberculosis is less than 10 cases per million population. So we know tuberculosis tuberculosis bacilli is the most successful pathogen of all time. We know that it is there since antiquity, and still we are struggling to first we struggle to control it, then now we are trying to eliminate it, but it is still there. And it is still means we are in a struggling position now. So we know since last you can see in the on the slide that since last 200 years, almost 100 crore people died of tuberculosis. And we know that this tuberculosis is one of the top 10 cause of death and is a leading cause from single infectious disease. TB contributes almost 4.5% of the total deaths in India. And we know the tuberculosis is just not a disease, it is a social problem. There is a stigma also associated with it. And tuberculosis, poverty and malnutrition, it forms a vicious cycle. And this vicious cycle makes this bacilli again very reluctant for elimination. And we know just health department can alone will not be able to eliminate this tuberculosis. We need to have a multi-sectoral approach. We need to work together, private sector, public sector. Within public sector, all the departments, we all need to work together for elimination of this deadly disease. We know overcrowding, poor housing, indoor air pollution, comorbidities like diabetes, HIV, smoking. These are all determinants of tuberculosis, which fuels the existing epidemic. And we know we have some underprivileged population also, that is tribal and migrant population also, and we need to devise innovative strategies for eliminating tuberculosis in this population as well. As far as TB dynamics is concerned, we know um, if one patient with infectious pulmonary TB can infect 10 to 15 persons in a year if left untreated. And as far as risk is concerned, the lifetime risk for breaking down TB infection into disease is 10%, and this risk increases with HIV up to the tune of 60%, and in diabetic patient to the tune of 30%. Uh, so managing this, along with managing tuberculosis, managing other comorbidities is also very important. Uh, as per Global Tuberculosis Report 2020, almost quarter of the TB burden is in India, whether it is a drug sensitive TB or a drug resistant tuberculosis. And mortality is also much high. Almost 36% of the TB deaths are contributed by India. Childhood TB is also a serious issue. Almost quarter of the children with TB are in India. So it also indicates that there is active transmission going on in our country. So this is also important aspect. We know there is an TB strategy of World Health Organization, which says that we have to reduce the death, tuberculosis death by 95%, incidence by 90%, and there should not be any family having catastrophic cost due to tuberculosis. So as per ANTB strategy, we need to achieve this target by 2035. Uh, when we compare, when we compare the baseline value of 2015. As per SDGs, that is United Nations Sustainable Development Goal, we need to achieve this NTB goal. Means we need to reduce the death by 90% by 2030, incidence by 80%, and there should not be any catastrophic costs due to TB by 2020. So these are the targets set by United Nations and World Health Organization. But going ahead, India has decided to achieve this SDG target, means 2030 target, 5 years ahead of the globe. And with this ambition, Government of India has has developed a national strategic plan for elimination of tuberculosis, and it has also they have also made a huge financial provisions for this ambitious target. Um, uh, on 30th March 2018, at Delhi NTB Summit, Government Prime Minister of India has launched TB Free India campaign, and this campaign calls for social movement focused on patient-centric holistic care driven by integrated action for TB Free India. So as far as the achievement so far is concerned, incidence is declining with all these previously RNTCP and now NTEP's strategies. The incidence is declining, the mortality is also declining, but the current global trend of decrease in the incidence of tuberculosis is just 2 to 3%. And if we go by this pace, then we'll not be able to achieve this NTB target by 2035. What is needed? So we need to strengthen the existing strategies. We need to have a new tools. We need to have a universal health coverage, social protection scheme integrated into it, and even all these are strengthened. Even doing all these things will not be able to achieve for will not be able to achieve more than 10% per year decline. So what is needed? We need to have an effective vaccine, new drugs, shorter regimens. We need to manage LTBI effectively, and also we need to have a point of care test. So all the scientific organization and the research organization, they are working towards this goal, and they are involved in devising new vaccines, new drugs, new protocols, new point of care test, how to manage LTBI. So all this work is going on in the background, and as and when they get tested and the evidences are generated, and if the evidences are valid, then these are getting incorporated into the program. And in that way, this is the most rapidly evolving program of our country. So everything was going on track, but suddenly we know this COVID pandemic came, and last year almost the notification has declined. Drug sensitive notification has declined by 25% for drug sensitive patients and 17% for DRTB patients. So it has created a huge dent, and as already Munja madam told you, that this has put our program almost 8 to 12 years back. So this is a worrying factor. As far as Maharashtra is also concerned, Maharashtra is concerned, almost there is a decline of 30% TB notification in last year. We can see since lockdown, March 2020, there is a steep decline in TB notification, both in the public as well as private sector. There are various factors to it, which we already know. So what NTP did to mitigate this effect of pandemic? So it has started, means they have means Government of India gave directives to for uninterrupted TB services. They have devised a strategy of bidirectional COVID TB screening. That means every TB patient gets tested for COVID, and every COVID patient gets tested for tuberculosis. They have started, since the movement is not possible, so they have started OPDs based, means telemedicine consultation. They field worker moved from house to house for searching the tuberculosis cases. They have provided doorstep sample collection and delivery, sample collection and delivery of drugs, and timely Nikshay Poshan Yojana to the eligibles, and e-training and CMEs they were conducted. So notification has impacted, but there are no, means there are effects, but there is no major effect on the other public health actions like HIV testing, UDST. Treatment success rate of 2020 is around 82% nationally. DRTB treatment initiation is around 86%. So I mean to say this is a resilient sort of program uh, which sustains the um, unpredicted, unpredicted or unexpected impact. Um, So we know this national, as per national strategic plan, our objective is to build, strengthen and sustain an enabling environment for TB elimination, prevent emergence of TB in susceptible population, then to detect TB cases in community at early, and to treat all TB cases with quality drugs. So these are the main trust area of national strategic plan, and the private sector engagement is the most important of all these all these trust area. We know there are multiple WHO approved diagnostic options, and with the new innovations and new technologies coming into the program, the turnaround time has decreased. and at the same time the sensitivity for diagnosing tuberculosis has also increased. All these new molecular technologies and new diagnostic technologies are available under the program. This is the diagnostic algorithm for drug sensitive pulmonary tuberculosis, in which we know whenever there is a presumptive TB case, um, we need to offer X-ray and smear both simultaneously. And the whole purpose of this algorithm is to, means the crux of this algorithm is to have a microbiological confirmation of each and every diagnosed TB case. So first of all, we try to diagnose patient microbiologically, and if it is not possible, then there is a scope or window for diagnosing that patient clinically as well. First of all, we should try to diagnose each and every case microbiologically with the help of appropriate molecular diagnostic technologies like CBNAT and TrueNAT. And for key populations like PLHIV, pediatric, extrapulmonary cases, so there is a provision for upfront molecular technologies for diagnosing TB in the program. As far as pediatric pulmonary TB is concerned, this algorithm has also been revised recently, and now to all pediatric pulmonary presumptive TB cases. So pediatric presumptive TB case means the child who is having persistent fever more than 2 weeks with a known cause, or unremitting cough for more than 2 weeks, or if there is a weight loss of more than 5% in last 3 months, or if there is no weight gain, and if there is a history of contact of TB, then we call this child as a presumptive TB case. And in such cases, we upfront offer chest X-ray followed by CBNAT and skin test. And based on the results, we try to diagnose that case microbiologically. And there is only one scenario in the whole program where we give antibiotic trial. So in case of pediatric TB, if the X-rays are not suggestive and skin test is positive, in that case only we give antibiotic trial of 1 to 2 week with amox like drugs, and we avoid second line anti-tubercular drugs. And if there is a shadow persist or the symptom persist, then we evaluate that patient for tuberculosis. And in this algorithm also, there is enough scope for diagnosing the pediatric TB case clinically. This is the algorithm for diagnosing extrapulmonary tuberculosis. In this also, we extract the appropriate specimen from the appropriate site, and we try to diagnose that case on the basis of CBNAT, liquid culture, or available technology. So we know CBNAT, there are 4 modules in only 2 hours the result is available. The sensitivity for pulmonary TB in adult is almost 88%. And if the patient is smear positive, then this sensitivity increases to 98%, and the specificity is 98%. And for diagnosing the RIF resistance, the sensitivity is 95% and specificity is 98%. So the CBNAT simultaneously diagnose MTB as well as whether that sample is resistant, or that bacilli is resistant to rifampicin or not. So in case of extrapulmonary specimens, the sensitivity is little bit less, but still it is acceptable because there is a scope for diagnosing that patient microbiologically. And in almost all samples, the specificity is to the tune of 98 to 99%. So we know this new expert MTB XDR cartridge are also it will be shortly available in the program. So they will detect resistance to isoniazid, fluoroquinolone, second line injectables like amikacin, kanamycin, capromycin, and ethionamide in a single test, and that is within 90 minutes. So this will be an evolution, means this will change the whole scenario. So all the second, means first line as well as second line DST will be available within 90 minutes, and we will be able to put the patient correct regime. So it can potentially improve access to rapid drug susceptibility testing, especially for ruling out FQ resistance, which is required before starting the shorter oral BDQ containing MDR-RR regime, which is just been incorporated into the program guideline. So the similar to CBNet, we have another technology called TrueNet. It is almost comparable to CBNet with the comparable sensitivity and specificity. So for and all these technologies, whatever I am telling, means the diagnostic technologies, they are accessible and available for private sector as well. What they need to do is, if there is a suspected case, then we need to collect two fresh sample. One should be early morning and one spot in Falcon tube, which will be available through your district TB office, and the sample should be good quality and with a minimum 5 ml quantity. And then we need to transport this sample to the CBNAT or molecular diagnostic labs of public sector, and within a day or two, you'll get the report to your doorstep. So, as far as DST is concerned, drug susceptibility testing is concerned, under the program, we have both genotypic and phenotypic methods available. For genotypic method, we have NAT technologies like CBNAT and TrueNAT, and LPA line probe assay technology is also available for first line and the second line drugs. And growth-based technology like phenotypic drug susceptibility testing is also available under the program, and there are almost 6-7 public sector culture DST laboratories where all these facilities are available in Maharashtra. Along with this, to fill the gap, we government of Maharashtra has made an MOU with other private sector laboratories also, like Thyrocare, Metropolis, and all Hinduja, and they are also offering us these services. And these all services are free of cost to the patient, and program bears this cost if the laboratory is private sector laboratory. So we know the turnaround time almost. For NAT it is 2 hours, for LPA it is 72 hours, for liquid culture it is 42 days. Drug resistant tuberculosis, we know program is committed to provide universal drug susceptibility testing for all notified TB patients. UDST refers to rapid DST for at least rifampicin. This is a programmatic definition of UDST. So that is providing at least DST for rifampicin to all TB patients, and that too within minimum 15 days of diagnosis. And there are multiple technologies available under the program for offering this UDST, that is CBNAT, LPA, and TrueNAT. So you can see in this graph, with this new drugs and new strategies, the outcome has significantly improved. Outcome in MDR and XDR cases has significantly improved with these new diagnostic technologies and new drugs. You can see up to 2017, the success rate was to the tune of 49% in MDR cases and 34% in XDR cases, and it has now increase to more than 60 to 70% with the use of the shorter regimen and the BDQ containing regimen. So this is an integrated diagnostic algorithm for diagnosing DRTB cases. So I will not go in detail, but so we offer CVNAT to all the eligibles or NAT to all the eligibles, and if the R is resistant, rifampicin resistance is not detected, then we go for FLLPA, means first line LPA, and in that case, if R is registered, R is sensitive and H is also sensitive, then we start DSTB treatment. If R is registered and H is also R is sensitive and H is registered, in that case we give H mono poly regime to that patient. And if on NAT, and simultaneously we offer, we check for DST2 or resistance to second line drug as well. And if there is a resistance, based on the resistance pattern, we modify that treatment regime. If the NAT result is rifampicin resistance, in that case, we go for first line as well as second line LPA, and based on the DST pattern, we start that patient either on shorter regimen or the longer regimen. So, so now on 24th March 2021, the new PMDT guideline or revised PMDT guideline is released, which will be implemented in a phase-wise manner as and when the DSTs and these drugs gets available in the public sector. So what is new in this guideline is there is a shorter oral BDQ containing MDR-RR regimen and longer oral MDR-XDR regimen based on DST and DRT results, with scope in difficult patient to extend BDQ beyond 6 months, combined use of BDQ and DLM, and BDQ use in pregnancy. So these are all demands from the clinicians, and these are all unmet needs, and they are now all been included in these newer guidelines. So there are all the regimens are now oral regimens. There is no injections in any regimen. Current shorter MDR regimen, which has a second line injectable drugs, will be phased out and will be replaced by this shorter oral BDQ containing regimen. Eventually, these injectable second line drugs will also be removed from will be substituted by oral second line drugs. There is guidance on use of BDQ for children above 5 years and DLM for children above 6 years. And also guideline is considering to implement BPAL regime, which is a new regime. Just 6 to 9 month duration will be there for of this regime, and in which BDQ, a new drug pretonamide and linezolid will be used for treating this patient. Right now, the clinical trial is going on for this regime. If and post that clinical trial, this will be incorporated into the program. So there are major changes as far as treatment is concerned, treatment regimes are concerned in the guideline. So this is new diagnostic, means the same diagnostic algorithm is there in a revised guideline, but since we know the technology has improved, new DSTs, DST technologies are into the program. So based on that, this guideline is this algorithm is revised, and only major change is that shorter oral BDQ containing MDR-RR regime is now been incorporated or will be incorporated in the program in coming days. We know the MDR and RR-TB patient, these patients, there is a decentralized treatment option available in the program, and for that program has made district DRTB center in each and every districts, and now program is starting all DRTB cases, like H monopoly, shorter regimen cases, or simple or plain cases at district level, and those who require and those patients who has additional resistance to other drugs are now being managed at nodal DRTB center. So there is a decentralized approach. Patient need not have to go out of his district. He can take his medicine or treatment or regime at in his districts only. So we know there are missing cases, and we know the patient means there is a gap in the notification and actual incidence of cases, and we know where the gaps are, like private clinics, chemist, laboratory. These are all sources where from we can get the missing cases. And also for there are active case finding approach in the program, in which we go into community for searching these cases. So so program is trying to identify the missing cases and bring them into the notification system, and provide them the services which they are entitled to. Then under treatment option, we know for drug sensitive TB, we have a daily regimen with the help of daily FDCs are there in the program. Then we have universal DST. We are offering universal DST to all TB patients. We have the short regimen, new novel drugs like BDQ, delamanide, and decentralized DRTB services. These are the 4 FDCs. These are for drug sensitive TB patient. 4 FDC. You can see there are 5 weight bands, and based on the weight band, patient is given to either 2 medicine, 2 tablet, 3 tablet, 4 tablet, 5 tablet, or 6 tablet. Then there is a 3 FDC for continuation phase. Then these are pediatric FDCs. 3 FDC and 2 FDC, and there are 6 weight bands in the pediatric age group. And under the program, we are offering isoniazid preventive therapy to all the children less than 5 years of age who are close contact of TB patients. It is 5 year actually. It is written over here 6 year, but it is a 5 year. And they should be evaluated for active TB. And if there is no active TB, then all these cases will be provided preventive therapy in the form of 10 mg per kg INH for the period of 6 months.
Can you hasten this, because we are running, we are already over time.
Yes, sir. Yes, sir. Yes, sir. So we know. So the only change I already told you. So as far as comorbidities, sir, 5 minutes more will be required, sir.
Okay.
Yes. So TB comorbidities also need to be managed. So we know for HIV patients, we have a single window delivery system. Means all the HIV patients will get their TB medicine at ART center only. So for diabetic patient also, we have this bidirectional screening. For COVID patient also, program has implemented this bidirectional screening of TB COVID for augmenting the case finding activities. So these are the various algorithm for TB screening in COVID patients, then ILS, SARI patient. Essentially, all these cases are symptomatically screened, and if the symptoms are there, then we offer them chest X-ray and molecular technology. So we know in program we have this post-treatment follow-up as well, 6 month, 12 month, 18 month, and 24 month after completion of the treatment for identifying the early relapse. Private sector, we know almost 50% patients are there in private sector. Drug sale data suggests that if one case is in public sector, then the same number of cases will be there in the private sector. So for that, we know in Nagpur we have this UATVC program running on since 2017, in which there is a NGO which act as an interface between private sector and the public sector, and all these all the program, all the diagnostic and treatment facilities are available to private sector free of cost through this NGO. So like free X-rays are there, gene expert test, free gene expert and CBNet test for private sector patient is also there. There is a notification support, NICSHA notification support, as well as incentives are provided to the private sector. Government FDCs are also provided to the private sector. So there is a good collaboration of public and private sector in Nagpur, Nagpur Corporation, and for that we have engaged one third party agency also for facilitating this. So we know the private sector, we are very busy people, and we know for effective or good outcome of the TB patient, we need to have public health action. Just merely giving TB medication will not suffice or will not give a good outcome. For that, we need to have a public health measures into place, and in government setup, in public health setup, we have these field officers and field workers who can provide this, and like counseling of TB patient, contact investigation, chemoprophylaxis, HIV testing, all these things are necessary for effective or good outcome. And we need to take, or as a private practitioner, we should notify these cases to the public sector so that these public health measures or this patient can be linked to these public health measures to this field health workers. So even the private sector patient will get this public health action, and it is very essential for good outcome. And Nikshay Poshan Yojana, if private practitioner notifies the TB case, then that patient, if the patient is private sector patient, even that patient is also eligible for Nikshay Poshan Yojana in the form of 500 rupees per month till the treatment is going on. For providers or for the PPs or private practitioner, there is a notification incentive of 500 rupees and another 500 rupees for reporting the outcome on the Nikshay portal. So and also there are the incentives for treatment supporter. A private doctor can also act as a treatment supporter, and for that, if the patient is a new case, then he is eligible for 1,000 rupees per case after reporting a successful treatment outcome. And for drug resistant tuberculosis DRTB cases, it is 5,000 after completion of the treatment. Informant incentives also are there in the program. Beneficiaries are any volunteer except who draws salary from the health department, and benefit is in the form of 500 rupees per referral, and it is through DBT. All these incentives are through direct benefit transfer. We know there is a incentive structure as well as penal provision under the program also. So there are various modalities of notification. We know so there are hard copy reporting and the e-reporting as well. But the best modality is directly register yourself on the Nikshay portal and notify the patient from your account only. So you will be able to get the benefits on timely manner. So this is the Nikshay portal. So what is available for private sector under the program? So all the diagnoses, high-end molecular diagnostic technology, always as culture DST laboratories, access to culture DST laboratories is also there. For the private sector, you can refer your patient and get them diagnosed quickly. All the medicines, government FDCs, government medicine for drug first line as well as second line ATT are available for private sector as well, and the patient support to private sector patient. So we know it's time to come together to end the TB epidemic. Let's join hand together. And this year's World TB Day theme was that the clock is ticking. We know we have pledged to achieve or eliminate TB by 2025, and we are lagging behind. We have not achieved 2020 milestones. So the clock is ticking. We need to act fast. We need to come together to eliminate this deadly disease from our country. Thank you. Thank you very much. Thank you, sir. Over to Rajesh, sir.
Yes, thank you, Dr. Kadu. I think that was a very exhaustive uh, elaboration on the National Tuberculosis Elimination Program. My mistake, I called it Eradication Program previously. I think some of these diagnostic algorithms and all these, whatever important material is there, you can provide that to IMA so that can be circulated to all the doctors, all the members of IMA. Because if you want all the private practitioners to participate in this, they should have whatever material is available, and that should include what are the centers where CBNAT testing is done, important phone numbers. We should also inform the services which are free, so that once they have all this information, it is easy for them to participate in this. I mean, of course, most of the doctors are already participating. But if you want to have a complete participation,
yes, sir. Yes, sir. Definitely, sir. Actually, this 20 minutes is very less for NTEP, National Tuberculosis, means explaining the National Tuberculosis Elimination Program. But I shortly briefed everything. But if required, we can have a whole day sort of under the banner of IMA. We can have this session and we can sensitize all our private practitioner in detail on this program, because I have skipped lot of things, the management of LTBI and PMDT guidelines. I have skipped all these things. It is
Can I
just
add?
over. Yes, ma'am.
Can
Yes.
I add one line, Ballal sir?
yes.
If it does not break the purpose of this CME is to let all practitioners know that the program is being brought to them in a very friendly way so that their patients are benefited. Plus, because they are practicing, they should not lose money. और ऐसा नहीं है कि TB patient को charge नहीं करना. इसीलिए government has given an incentive when the patient gets cured, so that the private practitioner comes ahead and takes responsibility of not only diagnosing but curing a patient and keeping a record. That is important. Plus, patient आपका private में हो, government में हो, rich हो, poor हो, 500 rupees per month for 6 months will be given irrespective of the economic status of that patient. So there are many things which is making the program friendly for the private practitioner. Even the sample, if you are collecting any sample, whether it is pulmonary or extra pulmonary, there are arrangements that the courier will come to your clinic, collect the sample, take it to the laboratory and send you back the report. तो आपको और आपके पेशेंट को कुछ भी ज्यादा करना नहीं पड़ेगा, except that you follow the protocol and the guidelines given by the program. Thank you.
Yeah, that is true. That's why I said that we should circulate all these guidelines, important phone numbers, important names, where these things can be accessed quite easily by the private practitioners. I think we can turn to the next topic now. I believe it is by Dr. Sumer Chaudhary.
Yes.
The next topic. Dr. Sumer is an associate professor in the Department of Pulmonary Medicine, NKP Salve Institute of Medical Sciences. He has done his MD chest and DNB in respiratory medicine. He has 25 publications, and maybe more will be coming in index journals. And he has received some awards also, Teaching and Research Excellence Award from the IRDP Group of Journals, Chennai in October 2017, and the Academic EET CRS 6 Academic Brilliance Award from the EET. He has 18 certificates of appreciation in the research category. And let's hear what he has to say about the lab diagnosis of tuberculosis. Dr. Sumer Chaudhary, please.
Good afternoon. Am I audible?
Yes.
Hello.
Yes, sir.
Am I audible? Good afternoon. Today's my topic is laboratory diagnosis of tuberculosis. my target audience is the general practitioners, and my PPTs are prepared accordingly. So before coming to the laboratory diagnosis of tuberculosis, let me give you a brief introduction about the burden of tuberculosis globally. In 2019, 10 million people suffered from tuberculosis, whereas 4.65 lakh people among the people contracted drug-resistant tuberculosis, the dreaded tuberculosis. 1.4 million people of the, died because of TB, and of this 2,08,000 people were suffering from HIV. TB is the leading killer among the HIV patients and major cause of deaths related to antimicrobial diseases, antimicrobial resistance. The global efforts to combat TB have saved an estimated 63 million lives since the year 2000, since the inception of RNTCP. Every year on 24th of March, we celebrate World TB Day. This day is celebrated to make aware about the seriousness and graveness of the disease with a theme. And this year, this year 2021, the theme was "The Clock is Ticking," which conveys that the world is running out of time to act on the commitments to end TB by global leaders. And it's time to keep our promise that and end tuberculosis. Now coming to classification of tuberculosis. The Mycobacterium complex refers to a genetically group of species of which the importance to the human being is Mycobacterium tuberculosis. The other tuberculosis species are Mycobacterium bovis, Mycobacterium africanum, Mycobacterium microti, Mycobacterium caneti, Mycobacterium mungi, Mycobacterium orgeas, and Mycobacterium pinnipedi. But the importance to us is Mycobacterium tuberculosis. Now, what is, I will just, this has been covered by in the earlier lecture. I will just go through what is drug-resistant tuberculosis. Drug-resistant tuberculosis is when you have, Mycobacterium tuberculosis complex is resistant to two medications, that is rifampicin and INH. Then it is known as drug-resistant tuberculosis. What is XDR tuberculosis, extensive drug-resistant tuberculosis? It is when the MNDR TB, that is the tuberculosis is resistant to rifampicin and INH. Along with it, it is resistant to the first line. It is resistant to the fluoroquinolines and one of the injectable drugs, that is kanamycin or capreomycin. Then it is known as XDR tuberculosis. Now coming to the actual laboratory diagnosis of tuberculosis after seeing to the basics of some basic definitions in tuberculosis. Now, for every microbiological specimen to have a good result, it should be a good specimen. Results are as good as a specimen. Good quality sample is very important for laboratory accurate laboratory diagnosis of tuberculosis. Sputum samples of good quality collected in a wide mouth sterile containers. The quantity should be sufficient. Extrapulmonary samples collected in sterile containers and syringes. Now in this slide, you can see the first container is showing mucoid sample. The second container is showing purulent sample, which is yellowish in color. The first container is showing whitish color sputum. Then it could be a bloody sample because of some patient might be having pneumoctasis. This sample is also acceptable. But if the patient is giving salivary sample, then you should ask him to repeat the sample, because this sample you will not be able to give a proper or accurate laboratory diagnosis. Now, what are the sites from which you can collect the sample? In a patient of active pulmonary tuberculosis, patient who is expectorating, you can collect his sputum in the container, which I've shown in the previous slide. You can collect through bronchoscopy, bronchoalveolar lavage. If the patient is having disseminated tuberculosis, that is, it has spread all over his body, then you can collect from different sites like his bone marrow, liver biopsy, or blood cultures could also be done in these kinds of in these patients. If in the extrapulmonary patients, if they are suffering from bone or joint TB, then synovial fluid or synovial biopsy could be done. If he is suffering from tubercular pleural effusion, then pleural fluid or pleural biopsy samples could be collected. If he is having genitourinary tuberculosis, then a biopsy of the kidney can be done. If he is having lymphadenopathy tuberculosis, then collection of sample from lymph nodes, or that is FNSC, or you can do a biopsy, that is FNAB, lymph node aspiration biopsy. If he is having abdominal tuberculosis and having ascites, then you can send his ascitic fluid for investigation. And if is as well as you can send his peritoneal biopsy. If he is having CNS tuberculosis, then you can send his CSF fluid for investigative laboratory diagnosis. If a patient is having latent TB infection, this is the focus which we are making nowadays, that is labeled latent tubercular infection detection and treatment. We do is tuberculosis, to diagnose it, we do tubercular skin test, or nowadays we do a IGRA test, that is a whole blood IGRA test, immune gamma radio assay. This would be discussing in the further slides. Now coming to diagnosis of tuberculosis, if the patient is having active tuberculosis, pulmonary tuberculosis, you can send his sputum for smear microscopy. That is, you will see this his sputum under microscope. You can send it for molecular diagnostic tests, which have been which we will discuss, and in culture. If culture could be solid culture or a liquid culture, but nowadays preferable is liquid culture. For extrapulmonary tuberculosis sample, if the sample which you have collected, you can send this sample for a smear microscopy. You can send for PCR test. You can send for a liquid culture or a solid culture, but preferably is liquid culture. If you have a biopsy sample, you can send it for histopathological examinations. You can do a IGRA test or TST test. And if you have collected fluid, then you can send it for a fluid analysis. Now coming to smear microscopy. In a country like India, or a low, which has a low income and high tuberculosis prevalence, sputum smear microscopy is the most cost-effective tool for diagnosing patients with infectious tuberculosis and to monitor their progress in treatment. Sputum smear microscopy is a simple, inexpensive, appropriate technology method, which is relatively easy to perform and to read. This could also be done at a bedside in your clinic, in your hospital. The classical Xene stain is used for detection of acid-fast bacilli. Now, smear, if you are doing a smear microscopy, then the smear prepared should be from the purulent parts of the samples. The size of the smear should be around 3 centimeter by 2 centimeter. And you should examine at least 300 fields so that you can give proper interpretation of the smear microscopy. The smear is positive with the in the samples which contain 5,000 to 10,000 bacteria per ml. So the bacterial load has to be very high if you want to have a positive result in patients in case of smear microscopy. The sensitivity of smear microscopy ranges from 50% to 70%. Sensitivity increases by examining more number of smears, and the specificity of this is very high. It is about 98%. WHO has a policy of recommendation that at least 2 sputum sample stained with fluorescent stain and read by a microscopist under LED microscope in a laboratory participating in external quality assurance. So now a WHO recommendation is of fluorescent stain. This is how a uniform stained smear would look. It would be, this would be an adequate 2 by 3 centimeters, and after staining it would look like this. It should be a good even smear. It should have a good thickness. A too thin, uneven smear or a too thick smear, you would not be able to see the AFB bacilli and you would not be able to report the specimen properly. Smears are reported either as positive or negative. The quantity of AFB absorbed should be noted. The factors influencing the smear sensitivity are type of specimen, staining technique, experience of the reader. The laboratory quality control is a very important factor. This is how a smear would see, and these are the AFB bacilli seen. Now fluorescent microscopy, in this fluorochrome stain is used instead of AAB stain. The advantage is that you can examine the smear under a low magnification of 40 by x. It is rapid but has more chances of false positivity. The LED fluorescence microscopy has been evaluated. It gives rapid and good results, and the cost is also low. The LED attachment to the microscope is a Primo Star ILD, which is supplied from Carl Zeiss. This is how a fluorescent microscope looks, and this is how the smear looks under the fluorescent microscopy. Now, what are the advantages of a smear microscopy? Disadvantages of a smear microscopy. As I have told, it requires a very large bacilli load, that is 50,000 to 1 lakh, to be detected as positive. It cannot differentiate between dead and live bacilli. Even if the patient is having dead bacilli, it would be reported as a positive slide. It also cannot differentiate between Mycobacterium tuberculosis and non-tubercular Mycobacterium, NTM, and it can give no clue about drug resistance. Now coming to the cultures, there are this is the gold standard in treatment of in diagnosis of Mycobacterium tuberculosis. It provides definitive diagnosis of TB. The AFB culture can be done on 2 slides. That is can be done either on the solid culture or liquid culture. It gives a pure growth of mycobacteria to do specimen speciation and drug sensitivity. That is on AFB culture, you can do both speciation as well as drug sensitivity. Technically, it's demanding and complex. High level of biosafety is needed for AFB cultures. Now coming to the first AFB culture, that is the solid medium. In this, we all know that Lowenstein-Jensen media is used. It detects, there is a detection of 10 to 100 viable bacilli per ml of specimen. The specimen, before being inoculated in the LJ medium, it has to be decontaminated from the, and to remove the bacterial, normal bacterial flora. And the mycobacterium is slow growing, and hence it takes around 2 to 8 weeks to grow in this media. So if you are doing by LJ method, it would take a bit long time. That is, the turnaround time was 2 to 8 weeks. Now coming to liquid culture, these are the methods which are preferred nowadays, that it detects colonies of Mycobacterium tuberculosis in a liquid media. There are many commercial systems available like Bactec system, MGIT 960, Back Alert 3D system. As I have told that it gives rapid results, faster than the solid media, and the isolation rates of Mycobacterium are higher. The liquid media which is used in this is Middlebrook 7H9 media. MGIT media is commonly used, and it is a mycobacterial growth indicator tubes. It contains a modified Middlebrook 7H9 broth with a fluorescent quenching based oxygen sensor. Growth of mycobacterium leads to oxygen deletion, an indicator of fluorescence brightly. It can provide phenotypic DST results. That is, drug sensitivity can be provided by this media for both first line and second line drugs. And the results are available within 10 to 14 days. It is a gold standard for active TB tuberculosis diagnosis and has the highest sensitivity. Liquid culture and drug sensitivity is a key part of the diagnostic algorithm under NTEP. It should be routinely practiced on all patients with previous TB treatment and treatment failure. And treatment TB who are already received TB treatment or who are treatment failure, we have to send these patient sample for liquid culture DST. Liquid culture also helps in possibacillary TB cases, which could not be diagnosed by conventional methods. The limitation of this test is high cost and has a limited availability. This is how a liquid culture Bactec machine looks like, and this is the tube in which the Bactec media is. Now, drug sensitivity for AAB, this is depends upon the growth the growth on the AAB
Sumit,
solid or liquid media. Yes, madam.
Sumit, sorry
Yes,
to interrupt you, but please take only the sites
madam, these are all only of
related
laboratory
to
diagnosis. Yes, madam. These
diagnosis
are
for
laboratory diagnosis
lab
slides.
diagnosis.
Yes, yes, that was my topic.
Yeah, but
I am telling only
you
lab diagnosis.
take what
Yes,
is
madam. I am
related
telling
to
only what
private
is
practitioners.
relevant for the general practitioners.
Yeah. Please, because one more speaker
Yes,
is
madam.
there,
I am.
and then
It was because
people
of the
should not
earlier
wait.
lecture the time has been consumed.
Okay. But please.
Drug sensitivity for
It's a
AAB.
request.
Growth, it is a growth. Drug sensitivity is because it's a growth based test. It can be performed on the solid and like liquid culture media. The MGIT is preferred for both. DS is for both drug sensitivity test. In this, you do first line and second line anti-TB drugs are tested. The first line drugs which are tested are rifampicin, INH, ethambutol, and pyrazinamide. The second line drugs tested are streptomycin, levofloxacin, moxifloxacin, kanamycin, capreomycin, and amikacin. The other drugs which can be tested on these are linezolide, clofazimine, bedaquiline, dilamide, and paraminosalicylate acid. There are certain non-commercial methods which are can be used for DST but are not routinely used by commercial methods. One of them is microscopic observed drug susceptibility. It is known as MODS. In this, a microcolony method in liquid culture is inoculated on specimens into drug-free and drug-containing media and examine their early growth. The second is calorimetric redox indicator, in which it consists of a micro titer plate, and on this the different colors are visible, according to which you see for the resistant and sensitivity patterns. One more test available is nitrate reductase test, which is a non-commercial. In this, a direct or indirect method on solid culture based on the ability of Mycobacterium tuberculosis to reduce nitrate is seen, which is detected by color reaction. In this, you can see a control is showing blue color, streptomycin is showing blue color, rifampicin is showing blue color, while INH and ethambutol is not showing reductase. So these are probably resistant patterns. Earlier, we used to do serological tests, but this has been banned by WHO since 2011, like IgG, IgM, and should not be done on your routine clinical practice. Now, coming to the molecular test or gene tests which are done, two tests are done. One is Gene Expert, and second is line probe assays. The line probe assay test is a genotype MTB BDR plus test is also available. The advantage of this is that simultaneously you detect the resistant to INH and rifampicin. You can see the Mycobacterium tuberculosis complex, and along with it you see the resistant to INH and rifampicin. In this, the most significant mutations are detected, that is INHA, RPO, and CATG genes. It is based on a DNA strip technology. Can be done from, it is done from the positive cultures as well as from the positive smear, positive samples. Detection of multiple genes responsible for antibiotic resistance and simultaneous recognition of missing wild type genes can be done from this method. It is also available for second line and identification of some strains of non-tubercular mycobacterium. The limitation of genotype of this test is it needs pre-processing of samples. It needs a PCR setup. Technically, it is demanding. It causes panic of contamination. A special infrastructure is required and needs dedicated staff and space. Now, coming to the second molecular diagnostic test which is available is Gene Expert, and this is very commonly used nowadays for diagnosis and of Mycobacterium tuberculosis. Its short form is CBNAT. CBNAT means cartridge-based nucleic acid amplification test. It is known as Gene Expert. The expert gene is a cartridge-based nucleic acid amplification test in which you can detect Mycobacterium tuberculosis, along with that resistance to rifampicin. In earlier test, LPA, we were detecting resistance to both rifampicin and INH. In this, you can detect only resistance to rifampicin. In this, the samples which can be processed for CBNAT are your pulmonary samples, that is the sputum or bronchoalveolar lavage, and the extrapulmonary samples such as lymph node tissues, aspirates, CSF fluid, pus, gastric lavage, and aspirates in children and other tissues can also be processed in Gene Expert. The sensitivity of the CBNAT has been compared with culture positive and sputum smear positive, and it is found to have a sensitivity of 98%. In patients with smear negative and culture positive, it is a sensitivity of 68%. In people with HIV, it has a sensitivity of 79%, and people without HIV, it has a sensitivity of 86%. Extrapulmonary sites sensitivity and specificity has also been seen. Lymph node tissue and aspirate has a sensitivity of 84%, 84.9%, specificity of 92.5%. The CSF has a sensitivity of 79.5%, specificity of almost all samples except lymph node is 98%, while pleural fluid has a low sensitivity of 43%, while all other samples have specific sensitivity of more than 80%. Now for latent tuberculosis, we diagnose it through TST, that is tubercular skin test or Montoux test. This test is known by almost all general practitioners. It is a delayed type of hypersensitivity reaction in which 0.1 ml of tuberculin is injected intradermally. The test is read in 42 to 78 hours after the injection of tuberculin test. It is always measured in millimeter and only transverse diameter of induration is measured. You have to measure only the transverse diameter and induration. This is very important. There could be ulceration, vesication, bulla, lymphadenitis, necrosis should be noted whenever TST is given. However, it cannot differentiate between active and latent TB tuberculosis. It could only be used as a supportive tool in diagnosis of active tuberculosis, and its results are variable in immunocompromised patients. Now coming to IGRA test, it is known as interferon gamma released assay. Two types of IGRAs are approved. One is quantiferon TB and second is teal spot TB test. To conduct the test, fresh blood samples are mixed with antigens and controls, and the gamma interferon is measured. Interpretation is you get the interpretation within 24 to 48 hours. It is only meant for latent TB infection. It could be a supportive tool for diagnosis of active tuberculosis. It reduces sensitivity in immunocompromised patients, and it is not recommended for active TB diagnosis by WHO. It could only be used as a supportive diagnosis, as not the first-line diagnosis. Now the turnaround time for laboratory diagnosis methods are culture DST 84, that is the LJ medium, conventional medium, which is not done nowadays, rarely done only for detection of drug sensitivity, not in routine. Now the commonest test which is done is liquid culture, which takes up to 42 days. LPA requires up to 72 hours, NAT 2 hours, CBNAT 2 hours, IGRA 24 hours, and TST Montoux test 72 hours. So the turnaround time of CBNAT is the lowest, that is 2 hours. Now coming to the diagnostic algorithm of pulmonary TB, if suppose a patient comes to you who is you presume to have tuberculosis, then you will send his and he is coughing, he has expectoration, so you will send his sputum for smear examination and do his chest X-ray. If his smear is positive and chest X-ray is suggestive of TB, you will label him as a microbiologically confirmed tuberculosis. However, if his smear is positive but chest X-ray is not suggestive of TB, but his smear is positive, then also you will label him as a microbiologically confirmed TB and start him on anti-tubercular treatment. If the patient's smear is negative but chest X-ray is suggestive of TB, here the sputum smear is negative, send for CBNAT. And if CBNAT MTB is detected, and if it is resistant to tuberculosis, start on first-line treatment. If it is intermediate, then do a second sample for CBNAT. And if it is again indeterminate, then send for LPA and cultures. If it is resistant, start on DRTB. If MTB is not detected on CBNAT or results are not available, you can make a clinical diagnosis of tuberculosis or keep an alternative diagnosis. If the smear is negative and clinical suspicion is high, again follow the same algorithm. For extrapulmonary tuberculosis, if you suppose that the patient is having extrapulmonary tuberculosis and the specimen which you have collected is appropriate from the site, then do a CBNAT. So again, if the MTB is detected and rifampicin is sensitive, you label him as a microbiologically confirmed EPTB, that is extrapulmonary tuberculosis. For rifampicin indeterminate and rifampicin resistant, you follow the same algorithm as before. If CBNAT is not available, then send for liquid culture. If the culture is positive, microbiologically confirmed EPTB. If culture is negative, then no TB. If you don't have appropriate specimen and high clinical suspicion, then also you can start on clinically diagnosed TB. Now, in line with this laboratory diagnosis, I will just highlight the important points in management and treatment. For early diagnosis and management of TB, it is very important to prevent DRTB. India, TB is treated based on NTEP guidelines, as has been told in previous lecture. As previously, we used to treat in 4 categories, which has been eliminated. The first line drugs which are used as rifampicin, INH, ethambutol, pyrazinamide, and second line drugs as I've been told in the previous lecture. This is a RNTCP which used to follow earlier. As in this table is still followed in NTEP, and we have already discussed in the previous lecture that according to the weight bands in the adult as well as in the pediatric age group, we provide with the first line and second line drug. In the we provide first intensive phase and the continuation phase. In intensive phase, there are four drugs. And in the continuation phase, there are three drugs for both adults and pediatrics. In the adults, it is a single tablet having all 4 molecules. So you have to give 2 tablets, 3 tablets, 4 tablets. While in pediatrics, the ethambutol tablet is separated from the HRZ.
Okay, I think the next speaker is going to...
Last 2 slides. For indication of corticosteroids in tuberculosis, because we rampantly use corticosteroids, it could be used in tuberculosis pneumonia, biliary tuberculosis, pericardial pleural peritoneal effusions, in segmental patients having segmental opacities for preventing bronchiectasis, for suppression of hypersensitivity sensitivity, for tuberculosis management, and large lymph nodes involving or compressing the trachea. And my last slide is about just highlighting the different groups of drug resistant tuberculosis. According to the medications in the groups, you have to start on the drug resistant according to your available reports. You have to choose from the group A and group B, and if you cannot make a the regimen from these 2 groups, then you choose from the group C, and you have to start from the from above below. And as he is told in the newer to 2021, the injectables has been removed from the table. I acknowledge the assistance of Dr. Akansha Sarda and Dr. Gopal Agarwal, who assisted me in making these slides at a very short notice. Thank you very much.
Thank you, Dr. Chaudhary.
Sumer.
Yes, thank you, Sumer. That was a very comprehensive coverage of the lab diagnosis of tuberculosis. Of course, we, apart from general practitioners, we also have, apart from clinicians, we also have people who are pathologists and microbiologists, and many of this information would be very important to them. I think I'll straight away move to the next speaker, Dr. Gyan Shankar Mishra. He is a associate professor in the Department of Respiratory Medicine, Indira Gandhi Government Medical College, and there he's been since November 2017. He has a very keen interest in academics and research, and he has won the Best Young Teacher and Best Young Researcher Award by GRABS Education Trust, Chennai. He's published a book. He has a chapter in a book, and also many publications and citations in journals. He has reported the first case of schistosporiosis from exposure to cow dung. And to his credit, he also has coined the term and reported a case of Bindi tuberculosis. He will be speaking on the most important aspect in tuberculosis, that is prescription writing. I think I just wanted to give some introduction, but I'll skip that, and maybe I'll give my comments at the end of the lecture, because this is a very important topic as far as the control of tuberculosis is concerned. And we've over the last so many years, we have seen so many prescriptions. I'll just hand over the mic to Dr. Mishra, and we'll have our comments later on. Dr. Mishra, please.
Yeah. Thank you, sir, for the introduction. Am I audible?
Yes, sure.
Okay. So are my slides seen?
Yeah, we can see them. Okay,
sure. Thank you. So right now we'll be moving on to the next presentation, that is TB prescription practices. So the theme of this year's World TB Day is the clock is ticking. So is it really ticking for the TB prescriptions? Let's see. So in this webinar, what we'll be seeing is the following headings. So the first is current scenario of TB prescription practices. Then we'll move on to the fundamentals of TB chemotherapy. Then what are the components of a correct TB prescription? Then a bit about ATT dosing, an overview of chemoprophylaxis, and then a few case scenarios of TB prescription. So basically in 2013, we did a study, and we were astonished to find that only among the studied prescriptions, 9.52% of the prescriptions were correct. And in the government setup, it was 4.76. So the reasons were different altogether at that time. What we did is we did a review of literature then, and then found that almost all the studies had reported a similar outcome. That means the rates of incorrect prescriptions for anti-TB drugs were above 50%. All those from our country. So at that time, we had suggested that compulsory notification of the cases should be there, which is now there. And in the public sector, weight bands were not there. So right now it has been incorporated, and CME programs like this will help the cause. This was the first study by Uplekar, wherein they had found that 100 private doctors were studied for anti-TB prescriptions, and they prescribed 80 different regimes, most of which were inappropriate and expensive. This was done in the slums of Mumbai. And again, a decade later, they did a similar study, but the results did not change. So little seemed to have changed over the years. Now coming to the bacteriological fundamentals of TB treatment. There are certain principles that we need to follow when we write a TB treatment or prescription. So the number one and the most important is that it is a combination chemotherapy. So we need to write multi-therapy, or it is never a monotherapy. So it is always a combination of drugs that we give. The treatment is long term. It is not like 10 days or 15 days. It is for months, a minimum of 6 months. And then this is the most important, single dose administration. It is not to be given in split doses. It has to be given in single doses. So why is drug combination important? The combination of drugs prevents the appearance of resistance because it avoids naturally resistant mutant selection. Now let me just explain it by example. Like supposing if we have a wild population of TB bacilli, so there you will have one natural resistant mutant to INH in 10⁶ bacilli. Similarly, in 10⁸ bacilli, you will have one naturally resistant mutant to rifampicin. And in 10⁴ bacilli, you will have one naturally resistant mutant to INH and rifampicin. So what our inappropriate chemotherapy does is, or a single monotherapy does, is let's see. So this was just an example wherein they had given a single monotherapy of INH, and on the left you can see this is the bacillary count. So when you give a single INH monotherapy, initially the number of bacilli decreases, and this is the sensitive bacilli. And after a period of time, the number of drug-resistant bacilli increases. So overall, when the number of bacilli increases, after a certain period of time, it is a resistant. So initially there is a fall and then a rise. And this rise is of resistant mutants. So this is nothing but we give rise to a drug-resistant TB by giving a monotherapy. So monotherapy is absolutely contraindicated in tuberculosis. So whenever we give the chemotherapy for TB, it has to be a combination chemotherapy. The next is long-term treatment. So why we give long-term treatment? Because this permits action on all bacillary populations depending on the metabolic conditions. So in a TB patient, there are different bacilli populations formed of bacilli in different situations. It depends on the location, the pH, the replication rate, and the susceptibility to drugs. So the first type is rapidly multiplying bacilli. These are the most predominant population. The optimum medium for them is extracellular. They have a pH of where a pH of around 6.5 to 7 may be there, and they require maximum oxygenation. So it is basically the cavity wall where they are present, and these are present in very large numbers. So high probability of spontaneous natural mutations is present in these bacilli. INH is the most effective drug against these bacilli. Other drugs do act, but INH is the most effective one. Then we have slowly multiplying bacilli. These are inside the macrophages. They are present in the acidic pH. The population is less, and since the population is less, resistant mutants are not present. However, the most effective anti-TB drug against this bacilli is pyrazinamide. And the next is intermittently glowing bacilli. That means it will grow, it will be dormant for a period of time, and then again it will grow. So these are present in unfavorable conditions, basically in the solid caesium or in the granuloma way the caesium is there. These are extracellular. The population is less. Against naturally resistant mutants are not present in this population. However, this is the bacilli which is responsible for relapse. So therefore, to cover this bacilli, we give a longer duration of anti-TB treatment. The most effective drug against this bacilli is rifampicin. So in short, we have these bacilli, rapidly multiplying bacilli, where the most effective drug is INH, slowly multiplying bacilli, pyrazinamide. These are in the inside the macrophages in an acidic pH, intermittently growing bacilli, that is rifampicin. And then we have a fourth, that is bacilli in the latent or dormant state. So in short, here we will see in a single table, the extracellular rapidly multiplying organism, the most in the quantity 10⁸ Here the active drugs are INH is the most active, then rifampicin, streptomycin, ethambutol. Then in extracellular intermittently multiplying, it is rifampicin. Then inside the macrophages, it is in an acidic pH, it is the pyrazinamide. And in dormant bacilli, no first line drug acts. However, as of now, you have delaminate and bedaquiline that are supposed to, in vitro studies, they have shown action against dormant bacilli. Then the important point is single dose administration. Now, this is very important because it is very important for anti-TB drugs to achieve the blood peak levels, and it is also recommended that all the peak levels should be achieved simultaneously or at once. So for this, single dose administration is of help. Then the anti-TB drugs have some property of post-antibiotic effect. This was more important in the intermittent regime. However, in the daily regime also they have some effect. And giving single dose regime, it facilitates supervision. So the most important point is that these drugs should achieve the peak, and that too at the same time. Now, the practical implication of this is that 300 milligram OD of INH is not equal to 150 milligram BD of INH, because 150 milligram BD will not achieve the peak concentration. It will be a suboptimal concentration. When we see the time taken to reach the peak concentrations of the first line drugs, you can see that INH, rifampicin, pyrazinamide, and ethambutol, almost after 2 hours, they reach the peak. So to achieve simultaneously or at the same time, the peak concentrations of all anti-TB drugs, they should be given at the same time. So single dose is very important. So what is an ideal TB treatment? This is the regime that is right now recommended by the NTP as advocated by the WHO. 2 months of INH, rifampicin, pyrazinamide, and ethambutol, followed by 4 months of INH, rifampicin, and ethambutol. So 2 HRZD plus 4 HRE is the single first-line drug regime recommended for all TB cases. In the intensive phase, the main aim of the intensive phase is that the TB bacilli are killed rapidly, and in the continuation phase, the increased duration helps prevent the relapse. So this is the regime, 2 months of HRZD plus followed by 4 months of HRE. The continuation phase can be extended in situations like extrapulmonary TB, bone TB, spinal TB, neuro TB. And the important point is that the drug doses have to be as per the weight bands. The frequency is daily and the formulation is fixed dose combinations. Prior to writing a treatment, we need to do a pre-treatment evaluation. Now the pre-treatment evaluation, as already described by the previous speakers, it includes CBNAT. CBNAT means we are going for universal DST. You need to rule out resistance right at the start. Then chest X-ray in PTB, And then we have a bidirectional screening for HIV, diabetes. So therefore, you need to rule out HIV in all screen for HIV in all patients of TB, diabetes in all patients of TB, and LFT and KFT. These are baseline parameters to see if they are normal or deranged right at the start. Because if later on the patient develops ADR, then your baseline parameter of LFT and KFT will help you decide whether this is ADR or this was a pre-existing condition. So these are the minimum tests required before starting anti-TB treatment. So now coming to the important point, what is a correct anti-TB prescription? So a correct anti-TB prescription should have the following points. The patient's details should be mentioned, that is name, age, and the most important parameter here is the weight, because all the drugs are weight-based. All anti-TB drugs are weight-based. There should be at least 4 first-line anti-TB drugs. They should be prescribed unless contraindicated. The duration should be mentioned, like what is the duration of intensive phase, what is the duration of continuation phase, and this is a daily regime. All the drugs should be prescribed in doses as per weight, as per the WHO guidelines, and all the drugs should be advised to be taken at once or at the same time. A maximum gap of 15 to 20 minutes is permissible, but it should never be morning, evening, night. The prescription should not contain any second-line anti-TB drug in absence of confirmed resistance or other indication. So we need to rule out resistance right at the start. Universal DST, that means ruling out baseline resistance to rifampicin, and if necessary INH right at the start is very important. This is a component of the NT-EP. CBNet and LP are available under NT-EP, so the patients can be referred here. If resistance is detected, it requires expertise for treatment. Please refer patients to PMDT under National TB Elimination Program, or in plain words, refer to the government setup if drug-resistant TB is detected. Because drug-resistant TB is required to be treated, it has a prolonged duration, the treatment is costly, and it has more areas. So it requires some resources and infrastructure. And again, in the government setup, newer drugs like bedaquiline and dilaminate are available. So if drug resistance is recommended, if it is detected, then the patients can be referred to the government setup. So how does a drug-resistant anti-TB treatment look like? I'll not go into the details, but just see. These are the newer drugs, 4 to 6 months of intensive phase, 5 months of, this is the newer short oral regime. This is the injectable shorter regime. This is the all oral regime for MDR. And this is the INH mono regime. So it is not as simple as it looks, because there are many issues when you start the treatment. There are plenty of areas. There's issues of patient compliance. So it is better to prevent MDR rather than to treat. So if given an option, you want to prevent MDR or treat, so it is always better to prevent MDR. So correct diagnosis and management of drug-sensitive TB is the most important aspect in prevention of drug-resistant TB. We need to basically, whenever antibiotic trials are given, we should see that second-line anti-TB drugs should not be used. Antibiotics like linezolid, amoxiclav, ideally they should not be recommended. Plain amox can be given. So these are the fluoroquinolones, especially fluoroquinolones. They should not be the first-line antibiotics in TB suspects. So these are the all the anti-TB drugs, group A, group B, group C. So we should see that whenever we give an antibiotic trial in TB suspect, we should not use any of these drugs, especially fluoroquinolones. Now, an important point coming to the anti-TB drugs and food interactions. Ideally, it is recommended to give the drugs empty stomach. So we can see how the anti-TB drugs and food interaction is there. There are certain drugs that can be given with food. Means it is advisable to give them with food. It increases the absorption. Classic examples are clofazimine and bedaquiline. These are second-line drugs. There are certain drugs which can be administered with food because their bioavailability will not be hampered. The examples here are pyrazinamide and ethambutol. And there are certain drugs which are advised to be given without food. In the first-line drugs, it is INH and rifampicin. However, when given with food, the absorption is decreased by 57% or 26% respectively. However, even with food, their concentrations are still above MIC. So you can give, the practical implication is that we can give them after a light breakfast if the patient does not tolerate the empty stomach. So the point here is that all the first-line drugs, they can be given, the preferred is empty stomach, but if not given by empty stomach, we can give them after a light breakfast. So these are the doses. Right now, alternate day regime is not there. So the daily doses of H, R, Z, and E are 5, 10, 25, and 15 mg per kg in adults. And in children, it is 10, 15, 35, and 20. So the point is that in children, mg per kg is more than the adults due to the increased metabolism of the anti-TB drugs. One important point is that children above the weight of 25 kgs, the dosing moves towards the adults. So now the FDCs are available as two strengths. One is the 4-drug FDC. So here you can see this is the 4-drug FDC. It consists of combination of INH, rifampicin, ethambutol, and pyazimide. This is available under the National TB Elimination Program. So H 75 mg, rifampicin 150 mg, ethambutol 275 mg, and pyazimide 400 mg. Similar formulations with exactly same composition are available in the private sector. These are some of the brands available: Accurate 4, Track 4, Monitor 4, Micrate 4. So exactly same composition FDCs are available in the private sector. So the basic drug of the FDC will be the same, HRZE in the following composition. And this is the 3-drug FDC. Pyazimide is removed, and this is the FDC available under the program. INH 75 mg, rifampicin 150, ethambutol 275. And again, 3-drug FDC is also available in the private sector. Exactly same combination. Accurate 3, Track 3, Monitor 3. Again, the different brands are there. So this is a very important slide which gives us information about the different weight bands. So whenever FDCs are very simple to prescribe, but we need to follow the weight bands correctly. So here you can see that the intensive phase, we have 4 drugs, that is HRZE, and in contraction phase, we have 3 drugs, that is HRE. In the weight band of 25 to 34 kg, 2 drugs are required, 2 tablets, 35 to 49, 3 tablets, 50 to 64, 4 tablets, 65 to 75, 5 tablets, and more than 75, 6 tablets. Now this 6 tablets is too heavy, so if the patient does not tolerate, there is a liberty to shift it to 5 tablets. In the pediatric schedule, what the NTEP considers is that the pediatric age is less than 18. So all patients less than 18 years are considered pediatric, and they are given pediatric weight band FDCs. So here the weight bands are 4 to 7 kg 1 tablet, 8 to 11 2, 12 to 15 3, 16 to 24 4, and after 25 adult combinations are used in combination with pediatric combinations. So these weight bands are important, and whenever we prescribe the dosing for anti-TB treatment for these patients, we need to comply with these weight bands. We can have the chart of this beneath our table in the OPD and then see accordingly, rather than doing some errors. So the new pediatric RNTCP, the NTEP pediatric dosing, these are FDCs, these are soluble tablets, dispersible tablets, and they are flavored. So the patient compliance is increased in these new ones. Again, one important point is whenever we prescribe anti-TB treatment, especially in the pediatric age group, it is recommended to give pyridoxine 10 mg OD to all pediatric patients who are receiving anti-TB treatment. So the dosing in children is a bit different. It is more than the adults in mg per kg, 10, 15, 35, 20 of H, R, Z, and E. Again, important point is maximum dosing cap is there. INH can be prescribed maximum of 300 mg, rifampicin 600 mg, pyazimide is almost 2 grams. So we need to keep a point on the maximum dosing given to the patients. These are again the formulations under NTEP. These are disposable tablets. Again, they come in different flavors. Ethambutol comes separately, and also you have INH formulation separate if required to be added to the above. TB chemoprophylaxis, it has been discussed previously, but the point here that I would like to make here is that whenever you have a sputum positive patient who has less than 5 years of child at home, so you need to counsel regarding chemoprophylaxis. So not just if we diagnose a patient, we need to take history that how many under 5s are there at home, and in cases of infective or sputum positive PTB patients, we need to give chemoprophylaxis to the children also, or the active contacts. Similarly, if the mother has pregnancy, TB in pregnancy, then the babies of those mother are eligible for INH chemoprophylaxis. Patients on immunosuppressive therapy and HIV positive children with contacts. So the dose will be 10 mg per kg for 6 months. Right now, the program is also giving INH chemoprophylaxis to all HIV positive patients. This is just an algorithm for chemoprophylaxis. In short, if you have a contact with an infective case, then if the child is less than 5 years, rule out active TB and give 6 months of INH. If the child is more than 5 years of age, do a IGRA or you can do a Mantoux test, and appropriately you can give chemoprophylaxis if positive. An alternative regime that is under consideration right now is 12 dose weekly rifampicin and INH for chemoprophylaxis. Now coming to a case scenario. So this was just one of the recently encountered patient by us. So this was a 23-year-old male. So we'll just see a case scenario and see how a TB prescription is prepared. So this is a 23-year-old female. She presented with complaints of cough, expectoration, fever, loss of appetite, and loss of weight since 3 months. The chest X-ray was suggestive of bilateral upper zone cavities, bilateral patchy consolidation, mid-zone, lower zone. So it was suggestive of PTB. The investigations done were COVID RT-PCR and rapid antigen were negative, especially in these times. Sputum AB smear was negative. Mantoux was negative. However, sputum CB-NAT was done and it detected MTB low. Means mycovectum tuberculosis was detected even though in low amounts. RIF resistance was not detected. So the point here is that CB-NAT should be done in all cases. Even though it has a it will give us 2 points. It has a higher sensitivity than sputum AB smear. It will give us the presence or absence of MTB, and secondly, it will help us rule out RIF resistance or rifampicin resistance. We did a pre-treatment evaluation. LFT, it was showing a hyperproteinemia that is expected in TB patients. SGOT was slightly raised, but within 3 times of upper limit of normal. KFT was normal. Blood sugar was normal. HIV was non-reactive. So we need to write a prescription. So the prescription, these are the important components of a prescription. It should have a date. So let's write the date. The name, age, gender, and weight should be prescribed. So here it is mentioned here. The name, 23-year-old female, weight was 40 kg. We write a diagnosis that is microbiologically confirmed pulmonary tuberculosis. And then we write the supportive and pre-treatment evaluation investigations. So chest X-ray was suggestive of PTB, CB-NAT was showing MTB detected, RIF resistance was not detected. Then we did a screening test, HIV was non-reactive, RBS, LFT, KFT was normal. Now we are supposed to write a treatment. So treatment has 2 parts. One is we need to write the regime, and the second is we need to write the dosing. So the regime that we'll give is 2 months of EHRZ plus 4 months of HRE for all cases. And initially we need to give 4 drugs FDC. So what is the dosing as per the weight band? We can see here that the patient has 40 kg of weight. So the patient will require 3 tablets of 4 drug FDC initially. So this 4 drug FDC, that is HRZD, we will prescribe. Initially it will be 3 tablets OD, and we have to ask the patient to take 3 tablets at once for 1 month. This may be taken after a light breakfast. And then we need to ask the patient to follow up after 25 days. Important point here is that we need to ask the patient that whenever the patient comes for follow-up, she should continue with the tablets. That means if the patient is not able to come up after 1 month, she comes after 10 days later than an appointment, the anti-TB drugs need to be continued. So therefore, it's better to call the patient 5 days earlier. And all precautions should be taken that there is no gap in the anti-TB treatment. Supposing if we want to write an individualized regime or with individual drugs, then we need to calculate the dosing of the individual drugs. Like INH, the dose is 4 to 6 mg per kg. For 40 kg, it will be 160 to 240. So in market, you have preparations of 200, you can give 100 mg 2 tablets. Rifampicin 8 to 12 mg per kg. For 40 kg, the range will be 320 to 480. So here 450 mg, you can give individual drug. Ethambutol 15 to 20 mg per kg. So for 40 kg, the range will be 600 to 800. So we prefer 800. In anti-TB treatment, whenever you have a range, try to go for the higher side. Do not go for the lower side. Higher side, will lead to, means there is a risk of ADR which can be managed. But for lower side, if you give on the lower side, if it is underdosed, then that will lead to resistance. So this is just one of the principles that always go on the higher side. Then pyrazinamide 20 to 30 mg per kg. The range is 800 to 1200. We go for 1200. So accordingly, you can prescribe here tablet INH 200 mg OD. Rifampicin 450 mg OD, ethambutol 800 mg OD, pyrazinamide 1200 mg OD, and then you can ask the patient for follow-up. So the doses have to be calculated in mg per kg as per the patient's weight and prescribed accordingly. So this is more important. So you can see here that FDC prescription is a bit simpler. We need to add pyridoxine. So in all pediatric populations, 10 mg of pyridoxine is added. In adults, pregnant females, HIV, alcoholics, diabetics, and undernutrition, you need to prescribe compulsory pyridoxine. Now coming to the last part of the lecture, we'll just see a few anti-TB prescriptions. The point here is that we need to avoid mistakes in prescriptions, and our prescription should be error-free. So errors may sometimes be typographical. This was just one of the one X-ray report that a patient brought to me last week only. So as seen in the reporting, I suppose it was a typographical error. But non-typographical errors should definitely be avoided. So coming to the first prescription, this is a prescription of a patient diagnosed with pulmonary tuberculosis. They have written the weight, but the dosing they have written is tablet Accurate 3, 1 tablet BD. Now, what this is INH, rifampicin, and ethambutol. Underdosing this is a FDC, and this has been prescribed in BD dosing for 2 months. Now we see that the patient's weight was 40 kg. So Accurate 3, if it is to be given in the continuation phase, let's say, then the 3 tablets have to be prescribed. But here 2 tablets are given, and that too in split dosing. So this is suboptimal dosing. This will lead to drug resistance. The correct dosing for this would have been tablet Accurate 3 tablet OD 300. So all the tablets have to be taken at once as per weight band. Do not split doses of anti-TB FDCs. Splitting FDC dose will lead to suboptimal therapy, and this will lead to drug resistance. Now this was again a 57-year-old male. Weight was not mentioned. This was a case of pulmonary TB with diabetes mellitus with recently diagnosed COVID positive, and he was prescribed tablet Accurate 4, 1 tablet TID. So again, this is a FDC which has to be prescribed, means in single OD dosing, and this was prescribed in TID dosing. So again, here do not split the doses of anti-TB FDCs. Splitting FDC dose will lead to suboptimal therapy, and that will lead to drug resistance. Supposing if we consider that the weight was in the weight band of 35 to 49 kg for this patient, then the correct dosing of the Accurate would have been tablet Accurate 4, 3 tablet OD, all the 3 tablets at once. Now this was again a pulmonary TB case relapse. Here we can see that AKT4. Okay. Now this is a combination of 4 tablets that we get, H, R, Z, and E. So it was again prescribed in split dosing 1, 2, 1, and along with that a second line moxifloxacin was prescribed. So weight needs to be written on the anti-TB prescription. All the anti-TB drugs need to be given at the same time to achieve simultaneously peak concentrations against TB bacilli, and ATT should not be given in morning, evening, and night doses. So the INH peak will be there in the afternoon, rifampicin will be there in the morning, and pyrazinamide will be there in the evening. So they will not be simultaneously peak. So simultaneous peak is required for killing the bacilli. If that is not there, then the bacilli will generate mutations, and resistance may develop. Moxiflox is a second line anti-TB drug, and it should not be given in absence of confirmed drug resistance. This is one again prescription, 59 kg weight, tablet Accurate 4, 2 tablets were prescribed. So anti-TB FDCs have to be prescribed as per weight bands. So weight is 59 kg, but Accurate 4, 2 tablets are prescribed. So we see here that for 59 kg, 4 tablets are required, but 2 tablets have been prescribed. So this is suboptimal dosing. The correct dose would have been tablet Accurate 4, 4 tablets OD. Now this is one prescription that I got way back in 2011. Now this was in our research article we had published also. So here, other than ethambutol 400 mg BD, no other anti-TB drug was found in the prescription. So no combination therapy is there. This is a monotherapy with ethambutol. So this is against the basic principle of anti-TB treatment, that it has to be a combination therapy. So never prescribe monotherapy. Single drug is given, and that too in split suboptimal dosing. So patient will not respond. It will lead to drug resistance. So we should never give such prescriptions. It should always be a combination therapy. Now this was a recent patient. just last week the patient had come, a case of TB spine, came to us on 25th March. We can see here that the patient was prescribed INH 300 mg in the morning, ethambutol 800 mg in the evening, levoflox 500 mg in the morning, and then after 10 days, pyrazinamide 750 mg was added in BD dosing. The point that struck to me was, why was rifampicin missing? Now this is obvious that what we are getting here is H, E, and levoflox, and later on pyrazinamide. But why rifampicin was missing? So I went through the records and then got this record. The prescription was started on 8th Jan and the record is of 5th Jan that the patient was rifampicin resistant, MTB detected and rifampicin resistant. So sample was also sent for culture. It was culture positive, but DST reports were not available. So the point here is the treatment of rifampicin resistant TB was attempted with all but one first line drugs. So you had given all first line drugs, only one levoflox. Levoflox was the sole second line drugs in the regime. Analysis of the, when we analyze the first line anti-TB prescriptions, INH was there in the morning, ethambutol in night, pyrazinamide was in split dosing in morning and night. So as already said, DRTB treatment is based on separate principles and the regime is different depending on the type of resistance. We had published a NDRS survey report analysis, which was the first from the India, and there we had seen that there was no rifampicin monoresistance. Always it is accompanied by INH resistance also, and therefore the program considers rifampicin monoresistance as MDR-TB. Currently, this is the regime that the program recommends: 18 to 20 months of levoflox, bedaquiline for 6 months, linezolid, clofazimine, and cyclosin for MDR-TB. And here, since the patient had taken levoflox along with this regime, so we will have to change it to high dose moxi probably. So the point is, if we get a drug resistant patients in absence of requisite expertise, I think it's better to refer the patient to go and set up or expertise where it is available. So coming to the end, the message that I would like to give is that always in an anti-TB prescription, it should contain the name, age, and weight. At least 4 first-line anti-TB drugs should be prescribed. The duration of IP and CP should be mentioned, like 2 months of EHRZ plus 4 months of HRE. All the drugs should be prescribed in doses as per the weight band prescribed by WHO. All the drugs prescribed should be taken at once or at the same time within 15 to 20 minutes max. The prescription should not contain any second-line anti-TB drug in absence of confirmed resistance or other indication. One important point is that linkages with NTAP can be done in private sector for drug dispensing in clinics and pharmacies. What this will do is, this will give a correct dosing, correct prescription, and prescription errors will be minimized. In the absence of requisite expertise or resources, it is better to refer drug-resistant TB patients to the program. We need to be cautious in pediatric and obese patients regarding drug dosing. So today, error-free anti-TB treatment prescription is the need of the hour to achieve the NTB targets, and therefore the clock is ticking, as we need to prescribe error-free anti-TB prescriptions. Thank you.
Thank you, Dr. Mishra. That was a very important topic which you have covered very nicely. There are some things which I want to add.
Yes.
Now, if Dr. Munje remembers, I was a lecturer in TB in 85, from 85 to 88. And at that time also, we were giving the same lecture to private practitioners about the proper prescription practices. And since last 35 years, we've been doing the same. And it is very disappointing and surprising that we still have such prescriptions, because treatment of tuberculosis is so mathematical. I mean, you just have to find out from the literature what drugs to prescribe whenever you diagnose a patient of tuberculosis. I believe if this doesn't work, I mean, it's not worked for the last 35 years. I don't see why people would suddenly start prescribing properly. Let us hope, I mean, I'm an optimist, let us hope that they do it. But there should be an alternative method by which we should make certain that all prescriptions are proper. And as Dr. Sanjay Devtore has suggested in one of the questions, why not we have a standard prescription where they just have to write down the weight and tick that, and whatever according to the weight band, that prescription would be there with the patient.
Like the NTP.
Alternatively, we have so many new things now. Why not prepare an app for this? I think that would be very easy, and that is something which I believe Dr. Kadu and maybe Dr. Munje, they can look at this. If you prepare an app, all the doctor has to do is go to that app, write down the diagnosis, pulmonary, extrapulmonary, put in the weight, and whatever the standard prescription that would come on that. That is something which can be easily worked on. Only we have to think of other methods, because, as you said, time is ticking. And if we really want to achieve this elimination of tuberculosis by 2025, these are some things which we'll have to do, or otherwise we have, just as we have made notification compulsory, this is proper prescription will have to be made compulsory. Otherwise, we are fighting a losing battle. If these are kind of prescriptions that we are getting, and I also see so many such prescriptions. And surprisingly, I mean, I should not say this, but I find that MBBS doctors give more wrong prescriptions than BMS and DHMS. Because BMS, DHMS, they learn from the medical representatives and they give proper prescriptions. I've seen some of those prescriptions also. And unfortunately, MBBS, MD, they are more prone to give these kind of prescriptions. Dr. Munje, I would like to have some comments from you.
Yes, basically we have to understand that whether we are in the government sector, public sector, or a private sector, we are all together and we are committed to a good cause of writing a good prescription and treating tuberculosis till the end or to the stage of cure for that particular patient. I agree with many observations of Ballal sir, and of course Dr. Gyan and me are working together. I have found there are few things which holds back people from writing prescription. And first and foremost is everybody believes that I can diagnose TB and I can treat TB. Because multiple drugs are being used for treatment of TB, that means a combination of drug has to be used. And once the disease is taken control by the not only the tablets but body immunity takes over, many of your patients, even if you have treated wrongly, may continue to be quiescent and do not come back to you. That gives a false confidence to the treating doctor कि मेरा prescription बराबर था, even if he has done something wrong. We are not here to look at what is being done wrong, but we are here to make suggestions to make everything right and correct. So what Ballal sir says is correct. Second important thing is that not only that everybody can diagnose and treat TB, people still today, whether they are new practitioners or old, have some fear in their mind about rifampicin and rifampicin-induced hepatitis. Let me tell you, there are many more drugs which are more hepatotoxic and nephrotoxic than rifampicin. However, people still like to jumble with the doses of rifampicin, trying to give a lesser dose or a split dose, या उससे nausea होता है, vomiting होता है. मेरे एक patient को ऐसा हुआ. We agree all experiences are true, but that does not mean that you should be fletching with the doses of the anti-TB drugs and in turn causing harm. What harm are we causing is we are not treating patient completely and you are exposing patient to suboptimal drugs, giving rise to drug resistance, which is very, very bad. So I think that a message should go to all our friends who are practitioners, irrespective of whether they are MBBS, whether they are consultants, whether there are specialists of different specialities, BAMH or DHMS. There should be a uniform protocol of doing a diagnosis by sputum smear, or even the extrapulmonary sample is there, it has to be subjected to CBNAT. It is available free of cost to all patients, whether they are government or private. So please take this opportunity to offer free diagnosis to your patient. जो टेस्ट बाहर 3000 रुपीज का होता है, आपके पेशेंट को अगर टीबी प्रोग्राम में फ्री करके मिल रहा है, तो it is going to increase your popularity. If your patient is going to get anti-TB drugs free of cost, it is going to increase your popularity और आपका patient आपके पास बार बार आएगा with lot of faith and belief in you. So you can just adopt to the norms of National TB program of making a diagnosis free of cost, which is proper, which excludes rifampicin resistance. Give anti-TB drugs in FDC in a single dose as per body weight. If you have any issues, you can have everybody's number, including me, Ballal sir, Kadu, Gyan, Sumer, and the whole team of pulmonologists that we have. and we are always there to guide you from patient to patient, even telephonically, or answer to your queries by mail and WhatsApp. I think I think this is enough for the practitioners. They have been with us for, I think, more than 2 hours, Sushma, and we can have a
Yes,
very well
madam.
drafted, a better and a smaller CME next time.
Yeah.
Yes, ma'am.
Okay, madam. Thank you. So I want to congratulate all the speakers of today's CMEs, Dr. Aniruddha Kadu, Dr. Sumer Chaudhary, and Dr. Gyan Shankar Mishra. They have presented their work very excellently. So congratulations, all of you. So at the end, I want to say that according to the World Health Organization, tuberculosis continues to be the one of the deadliest infectious disease, claiming the lives of nearly 4,000 people every day and infecting 28,000. So we have to effort should be made to combat the TB to save the life of 63 million lives since the year 2000. And just now, as Dr. Radha Munje madam told, that the involvement of the private practitioner is very, very important when we want to eliminate the tuberculosis from the world. So I think I want to tell you only thing is that they should maintain the diagnostic algorithm. They should follow all the private practitioners should follow the diagnostic algorithm. There should be complete participation of them in this, and they should take the responsibility to diagnose the disease properly and to treat the disease properly and to eliminate the disease. Of course, we need the new tools, universal health coverage, diagnostic criteria, new vaccine, new drugs, new protocols. But whatever protocols and diagnostic algorithm is available, that should be followed properly, and prescription should be proper, because when we want to cure our patient, these are all important things. So with this, I request Secretary of Indian Medical Association Nagpur branch, Dr. Rajesh Savarbande, to propose a formal vote of thanks. Rajesh.
Thank you, madam. Thank you, madam.
Yes.
On behalf of IMA Nagpur branch, myself, Dr. Rajesh Savarbande, Secretary, thankful to Rajesh Bal for being here with us as a chairperson. I would like to thank all the speakers of today's CME, Dr. Aniruddha Kadu, Dr. Sumer Chaudhary, Dr. Gyan Shankar Mishra sir, for their informative lecture, which is very useful in day-to-day practice. I extend my gratitude to Master of Ceremony, our Joint Secretary of IMA Nagpur branch, Dr. Sushma Thakre madam. We are also thankful to Dr. Radha Munje madam and who is President of Vidarbha Chest Association, and Secretary Dr. Sumer Chaudhary for their association and cooperation with IMA. I would appreciate the presence of all the participants and thankful to Dipen, Chirag, and all the team of DigiShield for providing the technical support. Thank you all. Thank you once again.
So are you going to invite us for tea and snacks now?
Yeah, sir, you are cordially invited for that, but at our home.
Zomato or Swiggy should be there.
Yes, we can send.
Thank you everybody.
So
Thank you,
ma'am.
thank you,
Thank you,
everybody.
sir. Thank you,
Thank
Balla
you,
sir.
Munje
Thank you, all
ma'am.
the
Thank you, Ballar
speakers.
sir.
Thank you, Rajesh.
Thank you, Sumer. Thank you, ma'am.
Thank you.